Hello, students. My name is Miss Lee, and I will be teaching you about inflammation. Some of this is previously learned knowledge, and some of this may be new to you. So please pay attention. You need to view this prior to coming to the first class. Our first class will be exemplar-based. In other words, the examples that we're going to be going through to show you what inflammation can look like in several disease processes. So I need you to pay attention, take some notes, and also to review when I ask you to review A&P, because we will be covering several organs in this concept. It's a 4-hour presentation. You'll get 2 hours for inflammation 1 and 2 hours for inflammation 2. So I will have information for both classes, including this YouTube, set up on the Canvas site for you to peruse and stop and use as you will for being able to take notes. So inflammation. The definition is an adaptive response normal to what the body sees as harmful, such as allergens, illness, or injury, also known as the inflammatory response. So you probably have heard about this when you talked about how wounds heal, because the first stage is the inflammatory response. There are 6 signs or symptoms of inflammation. Okay, so you can quickly jot those down. And I will talk about some of those harmful things that can cause illness or injury, and things like allergens that include stuff like pollen, gas emissions from automobiles, also from industrial complexes that put out a certain amount of I won't say toxic fumes, but they're not the best, especially if people suffer from asthma, which is directly related to inflammation. There are physical agents, mechanical objects that cause trauma to tissues. If people have been in car accidents and have had trauma, including surgeries, because that is a break in the skin integrity of the patient and initially causes an inflammatory response, because that's part of healing. Okay, any kind of excessive heat or cold or radiation, chemical agents, external irritants, poisons, irritating gases that I alluded to earlier, and as well as internal irritants such as hydrochloric acid in the stomach and trypsin and amylase lipase in the pancreas, and we'll get more into that in the exemplars. Also, microorganisms such as viruses and bacteria that can also cause inflammation. So, what did you write down for your 6 signs and symptoms of inflammation? So they should be pain, and pain is from the tissue damage that's caused and pressure of accumulation of fluid. Okay, you'll also see erythema or redness around that area from increased blood flow to the area. Also warmth due to the increased blood flow to the area and the dilation of the blood vessels. Edema or swelling is from the increased vascular permeability, leaking fluid, proteins, and leukocytes at the site, as well as histamines, kinins, and prostaglandins. So the blood slows in these dilated vessels and could result in perfusion issues, such as compartment syndrome. And you'll learn more about that as you go on to level 3 and level 4. So edema or the swelling is the accumulation of fluids, so that pressure is what causes the pain. Also, functional impairment of the body part or system. Okay, so in order to know what the functional impairment is for that organ or body system, you have to know what the functions are to begin with. And that's part of A&P2, and that's what raises its ugly head in level 2, because we will be going over some of the anatomy and physiology here so that you understand what's going on with the patient. And due to those functional impairments of that body part or system, that is what the doctor and hence we treat on the patient. Okay, some of you may have put in induration. That is an inflammatory response, but it's very limited. Induration occurs when there is like a bug bite, mosquito bite, bee sting, something of that nature that causes a hardened area and lump where that injection was, or where that bite was. Okay. Also in your TB skin tests, okay, it's not the redness around that is measured to see if it's positive or negative. It is the amount of induration that is there when you get it read 48 to 72 hours after. And we will be covering that a little bit more when we do tuberculosis in infection in a couple of weeks. Okay, but I will be going over the different organs with their functions as they pertain to the exemplars in this presentation. Also, exudate. Okay, exudate is the fluid that escapes from the blood vessels that includes dead phagocytic cells and dead tissue cells. Okay, and that's really stage 2, okay, of what happens with you know, the inflammatory response. So what types of exudate are there? Okay, first there's serous, which is clear, straw colored, kind of pale yellow, thin in consistency, but it's clear, you can see through it. Sanguinous is blood from ruptured blood vessels. It's red, it's thick, it could have some stringy clots in there. Okay. Serosanguinous is a mixture of serous and sanguinous. So you're going to have the clear part of the fluid with some blood mixed in there that is bright red and thicker. Okay, it's not going to be pink because that means the red blood cells have lysed, in other words, opened up or burst, and that's not good at all. So it should be a mixture of, you're going to see a serous part and then the bloody part or the sanguinous part as well. And it kind of looks like, if you've ever seen your blood drawn and in a tube, and as it separates, the blood components go to the bottom and the serous or plasma component goes to the top. It's similar to that. Okay. And then there's purulent drainage. Okay. We're not calling it pus or pussy, and I will talk about that in a second. And purulent drainage is opaque. You cannot see through it. It's usually a thick consistency because it contains a large quantity of cells and necrotic debris. And the color is going to depend upon whatever organism is occupying that particular injury. So it could be white, it could be yellow, it could be green, it could be tan, it could be a mixture, you know, it all depends. And when we look at infection, we're going to talk more about purulent drainage and how to get a culture from wounds to be able to tell what kind of organism there is there. It also may have an odor that needs to be noticed. So when you're documenting purulent drainage, you want to make sure you describe all the factors here. Okay, so, and purulent drainage normally indicates the presence of infection. So when you document pussy, P-U-S-S-Y, what other meaning could be construed to that word? I used to be a forensic biologist many years ago in my very young life, and I was also an expert witness that testified on the stand about my findings. Now, this was before DNA testing. But when you're up there and a lawyer's asking you questions, okay, they will lead you in a certain direction. So if you're up there defending your documentation for some reason because there is a suit against the hospital and you're named as well, and you have pussy written down, they're going to take that and run with the other meaning. Okay. And that will put you on the defensive. It also makes you look like you are not professional because you're not using the correct terminology we need to use and document what you saw. You should be able to close your eyes with your documentation, and the person that's reading it should be able to see exactly what you mean. Okay, so whenever you're documenting any of these types of exudate, make sure you're going with the quantity, how much there is, okay, what you're seeing, those kinds of things, and kind of chart with a lawyer on your shoulder, because NSO, where a lot of you get your liability insurance, has had seminars at conventions that say that most lawsuits against nurses are won because our documentation is not specific as to what we've maybe taught the patient, what we're seeing with the patient, their response, all that kind of stuff, very detailed, will definitely, paint a different picture than just, using terms that are not professional and are not medical terminology. So just remember that. Okay. So as we go, here's a question, and we can discuss this in class. Can there be infection without inflammation? And then if you say it can be, when? And then if you say it can't be, tell me why. So just write that down and we will discuss it in class for sure. Now, we talked about one of the first things that happens in the inflammatory process is the patient feels pain during inflammation. So an assessment of pain, we use the mnemonic device, PQRST. And that helps us chart completely as well as to how the patient is perceiving this pain. Okay, so this was adapted from Patricia Morton, Health Assessment in Nursing from Springhouse in 1993, and June Thompson and Susan Wilson in 1996 of Health Assessment for Nursing Practice by Mosby. And even though those are very old references, it still holds true because it helps us assess that pain completely. So P is provocative or palliative. So what causes the symptom? What makes it better or worse? What home remedies or what have you tried to help it feel better? And is there any body position that relieves the symptoms? Okay, what makes it worse? What makes it better? Q is the quality or quantity of the pain. So basically, the quality, because you want them to describe how does the symptom feel, look, or sound, describe, whether the symptom disrupts activity. Can they walk? Can they take a shower? Can they do their activities of daily living? How much of the symptom are they experiencing now? And describe the sensation, which is basically the quality. Is it burning? Is it aching? Is it stabbing? Is it dull? Does it throb? Does it itch? Is there a slow onset, or is it all of a sudden and abrupt? R is region or radiation. In other words, where is that symptom located? Okay, what region of the body? And then does it spread or does it radiate somewhere else in the body? Okay, and then do other symptoms appear at that time? Some people, when they experience a lot of pain and it's sharp and it's just really throbbing, they can get nauseated. So that is another symptom that they experience at the same time. S is the severity scale. Okay, so how does the pain rate on a severity scale of 0 being no pain and 10 being the worst pain they could ever experience? Okay, and then we also like to get a pain goal from them. What is the level of pain that they can tolerate and still be able to function doing their activities of daily living, maybe going to work or what have you? And we shoot for that goal in the hospital and possibly as outpatient if you work in a clinic and that kind of thing. So that's very important. Not only are you going to find out about the 0 to 10 scale, the face scale as well. If they can't quantify it into a number, they can point to the face. And that's very handy for pediatric patients to do. And then the timing. Is there a specific time of day when the symptoms occur? How often does it happen? And when do the symptoms begin and do they end at a certain time? So all those things are very important to chart and be complete about. And then remember, when you give something for pain or you do some alternative therapy, such as progressive muscle relaxation with them, visualization, distraction, those kinds of things, or give them pain medicine, you have to come back within a half an hour or 45 minutes. Even changing position can make a big difference in relief of pain. So, did that help them when we did this? And if not, what else can we do? So general laboratory testing for inflammation, these are just general labs that you might see on the chart. Some of them are included in your clinical lab sheet, and we will, and I allude to that on the PowerPoint if the value is already on the lab sheet. And I will also give it to you during the course of this presentation. So the ESR, or the erythrocyte sedimentation rate, which can also be called the SED rate, you might hear that referred, is not on the clinical lab sheet. Now, we're endeavoring to put it on the clinical lab sheet, and so look for that later on when you're in clinical and print that up. But it measures how far erythrocytes or red blood cells settle in a tube, usually over 1 hour. In the presence of an active inflammatory response, those red blood cells stick together and settle faster, causing a higher reading. So the values that are normal for males, it's 0 to 15 millimeters per hour, and for females, it's 0 to 20 millimeters per hour. Well, those are really close. So just know that for general population, males and females, if it's over 20 millimeters per hour, then that denotes inflammation. Okay. Your testing is, I am not going to give you something that says 16 millimeters per hour. Okay. You're going to be able to tell. The C-reactive protein is another thing you may see in the labs when you check your patient's charts. And that is produced by the liver and fat cells in response to an inflammatory process. The normal range, which is on your lab sheet, is less than 1 milligram per deciliter. That's pretty easy. Anything over 1, is going to be denoted to have an inflammatory response. Okay. Now, both of these particular labs are non-specific. They tell us how hot the fire is, how bad the inflammation is, but just not where it is. So, those other symptoms help tell us, where this inflammation might be. And of course, a CBC with DIF, and a CBC, of course, is a complete blood count with a differential. And the differential has to do with the types of white blood cells that occur. So you get a general white blood cell count, okay? And all this is on your lab sheet. And then you get your red blood cells and your hemoglobin and hematocrit. And when I teach you study skills and test taking techniques, we will go over how you can memorize or know some of these basic labs just to look at them and not have to worry about the reference ranges. Although in your clinical setting, you will always have those reference ranges, and of course on your lab sheet as well. So first are your neutrophils of the white blood cells, and they are evident in acute infection, inflammation, or stress response, and comes from bone, and it can be through bone marrow depression as well as viral infections. Eosinophils, parasitic infections, autoimmune disorders, and allergic reactions, as well as stress in certain drugs. Basophils, hypersensitivity responses, hypothyroidism, and they're usually already low. Okay. Monocytes, chronic inflammatory disorders, infections. Can also be from corticosteroid therapy, and lymphocytes, infections, viral infections, lymphocytic leukemia. So bone marrow depression and immunodeficiency will cause problems with that. Okay. So that's part of assessment, right? You're going to look for where they have pain. If you can see redness there, is there warmth to the skin, right? So edema, exudate, all those different kinds of things that we mentioned. So when you're looking at that patient and you're talking to that patient, you need to establish goals that you and the patient feel are important. They must be specific to the patient, realistic, and measurable and achievable within a given time period. So you can have a short-term goal. Say the patient is in for surgery, okay, and they're exhibiting a lot of pain. they have some mild redness, maybe not so much edema with the incision, okay? And the skin is warm around the incision, but we also know that's a normal healing process. That's the first stage of a normal healing process. So short-term goal, we're looking, depending on the severity of the incision, those kinds of things, we're looking that inflammatory response may resolve over a couple days. And then we want to see it definitely, totally resolved by discharge. So those are the kinds of things you want to see. Also with goal setting, they not so much with inflammation, but you can see it with infection. They may have a fever. They come in, it runs between, say, 100.8 and 101.9. Well, specific to the patient, that's what you're seeing as recognizing a cue and analyzing it. What does that mean? So if they have a fever, well, then their white blood cell count is probably going to be up. You're going to see that. And so those two things, you want their temperature to be within a certain range, okay? And you want their white blood cell count to be within the normal range as well. Now, when I say temperature to be within a normal range, it depends. Elderly run lower, right, than a normal adult person. So, it's specific to the patient. It's realistic. It's definitely measurable by either a CBC with the white blood cell count or taking vital signs with the temperature, and can be achievable within a given time period. So if they're on antibiotics, in 3 to 4 days, depending on the severity of the infection, you want to see, and you trend the data. You want to be able to see a decrease over time with the white blood cells coming back to normal. You want to be able to see their temperature, resolving back to normal without spikes of fever. So, and definitely by discharge, you want those things resolved. So that's just an example for patient goals. The general interventions for inflammation and therapies. So for injury, okay, you want to reduce the mobility of the involved area. So, they may be, because it hurts to move, depending on where it is. If I have a cut on my thumb, a paper cut, it may really hurt to move it. So I might keep it straight for maybe a day or so until that inflammation starts resolved, the redness starts going away. I'll put it up so that elevation will help reduce the edema. For bigger inflammatory things, antipyretics such as NSAIDs and Tylenol and aspirin, those kinds of things use PRN to bring down the temperature. And then anti-inflammatory medications such as non-steroidal anti-inflammatory drugs, okay, NSAIDs or steroids that reduce inflammation, okay? The thing about those two drugs is that they can mask an elevation in the inflammatory response that can also allude to the infection process. So things like surgery can cause an inflammatory response. And we'll talk about surgery with ulcerative colitis, which is UC, also Crohn's and cholecystitis. Antibiotics, okay? So we're going to treat that inflammation that's caused by infection. Steroids are good. in treating inflammation for severe systemic inflammation. And again, we'll talk about that with things, Dr. Uini will talk about it when you get to oxygenation and asthma, as well as ulcerative colitis and Crohn's, those types of things, to treat it with steroids. Dietary support. Anytime you have an inflammatory response, your body is going to need to heal. So the patient's body is going to need to heal. So their metabolism is going to rev up some. They're going to need extra calories. They're going to need protein, okay, because that's what a lot of blood cells need, as well as white blood cells to form and help fight infection. They're going to need carbohydrates, vitamins for healing. Also, you might consult the healthcare provider or the HCP to get a dietitian or nutritionist on board to help with picking out foods that fit this dietary support, the amount of calories, and things the patient likes to eat. Or if they're not big eaters, maybe some kind of supplement like Ensure or Boost with meals or in between meals. So some more general interventions or therapies. We want to prevent further injury to the patient, okay? So we need to also look at other things. You know, along with their CBC, you also get a platelet count. Okay, so what is that platelet count doing? What do the platelets do? Okay, as well as assisting with activity is ordered. If they're supposed to be up in the chair twice a day, we need to do that. We need, if they're supposed to be ambulating in the hall, we need to get them up and moving. You know, in the olden days, after surgery, they used to have imposed bed rest for weeks. You know, they give them laudanum, which is a type of morphine, which, you know, depressed their respiratory system and made them sleepy, so they didn't move. There was no turn, cough, and deep breathe at that time. And so a lot of patients, when they thought that they died from surgery, it was actually pneumonia, because they didn't turn, they breathed less often and less deep. And so their secretions started to go ahead and accumulate and then consolidate and cause pneumonia, which then caused them to expire. So we need to make sure that our patients are doing the activities they need to do to get well. Okay. Also assisting with hygiene and activities of daily living as needed. The doctor may consult OT and PT. OT being occupational therapy that works the upper body, you know, doing dressing, you know, being able to dress and wash their face and brush their teeth and brush their hair and do things with their upper body with coordination and manual dexterity. As then physical therapy as well, to be able to get them out of bed safely and be able to ambulate them and assess their strength and their posture and being able to be safe when ambulating. We also want to alleviate their discomfort, and we alluded to that, or I did, with the pain scale and assessing their pain. So things that are just uncomfortable, like maybe they've been in one position too long and they can't physically move. You know, we're supposed to be changing their position, helping them change position every 2 hours if they can't do it themselves. Get as many people as you need and be able to turn them, remember? So especially if they have decreased nutritional intake and those kinds of things to heal, we can cause them to have more breakdown, which is also in our prevent further injury. We can have them have a bed sore in addition to having surgery. those kinds of things. So we really need to work together and do a lot of those things. Promote coping and decrease stress. I don't know of a patient that's in the hospital that doesn't have some kind of anxiety. You know, whether it be the IV pump that keeps going off, keeps beeping, somebody hollering down the hall that is confused. Um, you know, we're on a certain schedule in the hospital that they are not used to, you know, and all of a sudden we're telling them they can't eat a meal because they're going to testing. And, you know, they may be a little irritated about those things. So you need to be able to tell them why and address their concern or their anxiety and notice things about your patient and be able to comment, you know, you seem sad, you know, tell me what's going on. So, and you're going to get that if you're in mental health, that's part of therapeutic communication, but it all also addresses their need. And as a holistic person, you know, we need to address them holistically, which includes their mental health. Also, some intervention, the pharmacological that we talked, that's aimed at reducing the inflammatory response in pain. So what are some of those nursing considerations? I'd like you to write those down so that we can address them in class. So for NSAIDs, we talked about NSAIDs and glucocorticosteroids, that they may mask some infection because they are anti-inflammatories. They suppress the inflammatory response. So we have to rely on other things to give us indications of infection and that kind of thing. But they're also, NSAIDs are a very viable alternative for pain medicine. Okay, so we need to look at that, and the the healthcare provider might then say, well, you know, in lieu of all of this narcotics, if we can balance it by giving them some kind of NSAID, you know, a couple times a day, and then their other pain medicine, you know, in between, then they can have more pain relief and be able to do those things like move and turn in bed and things with less discomfort. So opioid analgesics, you know, we talked about, or I talked about being able to give those, but then we have to look for respiratory depression. One of the side effects that we kind of expect, they may end up being sleepy. So you may not be able to get them up and moving right away. You may have to give them, you know, some time to kind of sleep and relax, and then, you know, get them up and moving. But they definitely can turn in bed with that. But also, when you think about opioid analgesics, what else does it do? It decreases the motility, okay, of the GI system, so they can get constipated. So if they're not receiving a stool softener with the opioid analgesics, we need to address that with the healthcare provider to make sure the patients are able to have bowel movements and be comfortable, because there's nothing worse than being constipated, and, you know, nurses give enemas. So, you know, that's time consuming. It's also, you know, further insult to injury on the patient, which we don't want to cause. So if we can prevent it on the front end, it makes our life much better. And then natural therapies that decrease inflammation. Cumin is a big thing. And other things, you know, coming down the pike is the CBD oil that doesn't have the THC in it, that also addresses the cannabinoid system within the body. So you might find some older patients even taking CBD oil to help with whatever inflammatory responses they're having. But all of that needs to be taken into consideration, you know, in addition to the other medications they're taking. So not all of our patients can take in food, okay? Not by mouth. There are several different exemplars that the patients have to be NPO for, okay? Nothing by mouth, because like with pancreatitis, they put anything in their mouth, pancreatic enzymes are secreted that normally break down food. If there's a gallstone or if the pancreatic duct is swollen shut so that they can't be funneled into the common bile duct and then into the duodenum, it backs up into the pancreas, and you have amylase that breaks down starches, lipase that breaks down fats, and then trypsin that breaks down proteins. And they basically that auto digest that particular organism. So they are NPO from the time they are diagnosed. And they need nutrition, though, to be able to heal. So parenteral is the common way to go for their nutrition supplementation. Also with Crohn's and ulcerative colitis, they may be able to drink water and that kind of thing, but they need those proteins, they need those vitamins, they need all those other things, carbohydrates that are in that bag of parenteral nutrition to be able to heal. And they are basically on bowel rest because that is where they have the problem. So you don't want things going through that have to be digested. So parenteral nutrition can only be given through a central line situated in the subclavian artery on the chest, the jugular arteries in the neck, not arteries, I'm sorry, veins, subclavian veins, and then also in a PICC line, which is a peripherally inserted central catheter that is located in the antecubital or just above the antecubital of either arm and tunneled into, just like that central venous catheter would be, into close to that atrium, the right atrium. When it's inserted, it needs to be inserted per sterile technique. Okay. Before it's used, it needs to have confirmation of placement by an X-ray before use. Okay. So they can say, okay, start as antibiotics. No, that X-ray needs to come up, it needs to be read and the placement verified before you can start anything. Some of the complications of putting in a central line can be a pneumothorax, improper positioning, or a brachial plexus injury. Okay, so all of those things need to be addressed as well. The parenteral nutrition is made up of amino acids, a very high percent of glucose compared to what we'd be seeing in regular IV fluids, which is usually 5% dextrose. It's also made up of electrolytes and minerals, and lipids are usually given separately and usually 3 times a week. Okay, so the site needs to be checked every 2 hours for risk of infection, looking for redness, looking for swelling, looking for any exudate. Those sites are covered with a transparent dressing so that you can see those. And the faculty will be demonstrating the central line dressing change in the skills portion on Wednesdays and Fridays of this first week. Okay. Also, flushing the lumens of the catheter is very important to keep them patent. All right. So hospital policies can differ at sometimes, but you will get the central venous catheter or PICC line, all of that information in your IV therapy presentation that will occur either Wednesday or Friday. Okay. So another thing is that we need to monitor, since they have a high percentage of glucose in these nutrition bags that are hung every 24 hours with brand new tubing every single time. Okay. What do you think we need to monitor? Glucose every 6 hours. Okay. So we will be doing bedside glucose monitoring every 6 hours on that patient to make sure that their pancreas is meeting the insulin is meeting the glucose needs to put the glucose in the cells. Usually they'll be on a sliding scale of insulin, which you'll learn about in metabolism coming up in a couple weeks. And so if the patient needs additional insulin, we can give them that. When the parenteral nutrition is discontinued, we still, or what we want to do when the healthcare provider DCs it, we want to slowly wean them off of that parenteral nutrition to make sure their insulin is also matching the decline of the glucose and not staying up high, therefore causing a hypoglycemic reaction to the patient. Okay, so even once it's completely discontinued, we need to test them to make sure they are not bottoming out in their glucose. Okay, so those are things that are very important. And in your hospitals that you'll do clinical in, they have policies as to how often to flush the lumens of the central line, how, the dressing changes are due every week unless they're soiled or peeling apart, then they need to be replaced right then. Enteral feedings, okay, are tube feedings that go directly into the stomach, either by a nasogastric tube or a gastrostomy or jejustomy tube. Okay, so what that will entail, Dr. Uini will show you and demonstrate nasogastric and PEG tube and how the feedings will be. Okay, but they have to, again, the NG tube needs to be confirmed by an x-ray that it is in proper placement in the stomach. Okay, if the patient pulls it out some, if it got shoved in too much, the tape came off, or the placement thereof, it has to be then, pulled out or to where it was supposed to be, and an x-ray re-given to confirm placement. Because if they pull it out too much and you push it back in, it may not go into the stomach, it can go into the trachea and into their lungs. Okay, so best practices suggest use of litmus paper on aspirate to see if the pH is less than 4, which means it's in the stomach. Okay, and also we check what's called residual. Okay, for intermittent feedings as well as continuous tube feedings. We always, when we're giving medications or about every 4 hours, we stop the pump. Okay. And then we will hook our syringe, and Dr. Uini will demonstrate this during skills. And we pull back and see how much aspirate or how much tube feeding remains in the stomach. Again, hospital facilities have different policies as to, how much can be, what are you drawing back? Are you drawing back hundreds of milliliters and they're only getting 50 milliliters per hour? Well, number one, that means that somebody has not been checking the aspirates or the residuals. And number two, the big thing is that it's not making its way through the rest of the intestine. So what's going on? Okay, so most hospitals still auscultate for placement of the tube and check for residual. We don't instill air into our patients. Pulling back and getting gastric juices and tube feeding is a way to check. Most hospitals do not have litmus paper to check the pH. Litmus paper is expensive. It's only as good as the nurse that uses it. When they put it in the patient's room, sometimes it would get lost, or the nurse would put it in their pocket, take it home, never to return. Nobody else can use it. So there were a lot of different things. Enteral feedings or tube feedings can be given half strength or full strength as directed by the healthcare professionals' orders. They also can be specific to people that have renal disease, Nepro, and also those that are diabetic, a lower glucose level. Two of the most common complications are aspiration, especially with the NG tube, and diarrhea because of the high osmolality of the enteral feeding that pulls in the water into the colon and things, and they may have some diarrhea stools. Aspiration, those on enteral feedings are always, even with a PEG tube, which is a percutaneous endoscopic tube, gastrostomy tube. Okay, even with a PEG tube, when you're checking residuals, if that stomach is full of enteral feedings and they're almost laying flat, and they may not even realize it and be coughing and things, and that means maybe they have some GERD and it's coming up and they're aspirating on it, and it can cause them aspiration pneumonia, cause them pneumonia. So we need to keep those head of the beds elevated at least 30 degrees at all times. If you need to go in there and change the position of the patient, maybe change the patient if they've had a bowel movement or they're incontinent of urine or feces, or even to turn the patient. Okay, you need to turn off the pump for several minutes, gather your supplies, okay, then turn the patient, clean them, whatever you have to do, raise them up back to 30 degrees or higher, and then turn back on the pump. Okay, so that reduces the risk of aspiration. Dehydration can also be a factor because of the amount of water that's pulled into the colon and that keeps going and can cause diarrhea. If that patient for some reason is also taking a diuretic, you need to be very mindful of them being, having dehydration. So watch their urine output like a hawk. Okay. And also, when they're getting tube feedings, they should be having some kind of water flush to keep them hydrated, whether it's a separate bag on the pump that every 6 hours gives them a certain amount, or you have to manually give them a certain amount of water every so often, as indicated by the healthcare provider. Very important to keep them hydrated for free water. So monitoring their fluid and electrolytes is very important with this. Okay. Some other common interventions that we do all the time that helps with being able to assess our patients are vital signs. You know, depending on the floor, we might do them every 4 hours. If for some reason they're a little bit more acute, we might be doing them every 2 hours. And then as needed, somebody says, oh, I'm feeling warm. I think my temperature's up. We can't just say, oh, well, I just took it 2 hours ago. You're not due for it for another 2 hours. You need to be able to take that temperature. Also, when we're talking about all these GI organs, okay, we need to assess the abdomen. Remember, we inspect first, okay, for distension, ecchymosis. Do you remember what that word is? That's bruising, okay, any bruising that's going on. And then we auscultate, okay, each quadrant for bowel sounds, remember? So know what your normoactive, your hypoactive, your hyperactive sounds, you know, how often do they come about, okay? And then if we did percussion, it would come next, okay? Regular nurses don't, but, you know, a patient may ask, what did that, you know, why did that doctor do that? And why didn't you do that? You just, you know, looked and then you listened and then you palpated, okay? But you need to know the order, okay, to be able to tell them, you know, what's going on. So when we do palpate, we're going to see if it's soft, if it's firm, okay, and be able to do that as often as, you know, every 4 hours, if that's where their problem is. Maybe even every 2 if you're watching for something, okay? We're also going to assess hydration status, okay? Hydration status is most accurately measured, okay, from weighing them every day. In the morning, after they void, same scale, same clothes, okay? Very important. If they've gained 2 pounds, that's not fat, that's water weight, okay? And if they have other comorbidities with besides the exemplars we mentioned, such as perfusion issues that Ms. Hanhart's going to talk about, then that becomes very important with heart failure patients and those kinds of things. You know, if some of these ulcerative colitis or Crohn's patients, you know, they may come in dehydrated because they have so many diarrhea stools at a time and have all that water loss. So fluid and electrolytes and their hydration becomes very important. So we want them to be able to gain some of that weight back. So yes, looking at their mucous membranes upon assessment, skin turgor, okay, weighing them daily is the most important and most accurate way of telling, you know, how hydrated they are, okay? Mucous membranes, any tears, sunken eyes, those kinds of things. We talked about assessing for pain, monitoring their intake and output. We as nurses, that's an independent function, okay? Healthcare provider can order it, especially if he's concerned. It may be every hour, it may be every 2 hours. But if the patient's not on it, but we're concerned that they're not taking in enough or their output isn't where it should be, we can institute that and put them back on intake and output, or INO, to make sure that they're drinking enough, their output is enough for their kidney function, that's not being interrupted. Again, turn, cough, and deep breathe every 2 hours, or just turning every 2 hours. Making sure the head of the bed is elevated to reduce the risk of aspiration. You're going to see bowel rest for some of these exemplars, NPO status. We're also going to teach and reinforce that teaching as needed, PRN. Okay, so things to prevent further injury, to call us when they're getting up, to make sure that they are able to ambulate with a steady gait, that they're not off balance, that they don't become dizzy, pale out, and faint. That can be from meds, it can be from their pain meds, it could be from a whole host of things. So we need to be able to assess them and make sure that, they can get up safely. Okay, maintaining nutrition and fluids. Teach the family how to assist with caregiving. What do they need to do for this patient? So, and then all those other things that we talked about as well. So this is a review of the anatomy and physiology of the organs involved with each exemplar. Okay, refer to your anatomy and physiology books, please, as we go through this. For the functions, I list the functions, I don't elaborate. So if you have any questions about them, please refer to your A&P. Okay, let me see if I can get this. There we go. All right, so this is a picture of the liver, and it's divided into a right and left lobe, but it's located in the upper right to center of the abdominal cavity, just below the diaphragm. And you can see the diaphragm there in the picture right here. And you can also see the gallbladder that comes from the lower surface, the undersurface of the liver. Okay, so we're going to be talking about the liver as it relates to hepatitis in a few weeks with metabolism. Miss Marlowe is going to be, Miss Serpass is going to be talking about the liver as it pertains to liver failure, cirrhosis, that kind of thing. Okay. So here are the functions of the liver that can be impaired with inflammation. Remember, one of those symptoms is impairment of the functions of the organ or the system when inflamed. So the functions of the liver are just many: carbohydrate metabolism, amino acid metabolism, lipid metabolism, synthesis of plasma proteins such as albumin. So if you remember, albumin has a lot of hydrostatic pressure when it's present in the blood, and if it's present to the concentration it needs to be, it pulls that water from the interstitial spaces back into the circulating volume. Okay, if that albumin is decreased, then we usually have swelling in the interstitial spaces, because as with circulation and things, blood-based tissues, capillaries go out, the permeability changes and all of that. And then the veins take all the waste products and things back in as it comes out of the cells. And the albumin helps bring that water back into the intravascular systems. Okay, so that's very important. Also, the clotting factors like prothrombin, fibrinogen, and factor VIII. So all of those things are very important to know, that for functional impairment, if those clotting factors are not there, then the patient has a propensity to bleed. Okay, so platelets can be affected as well. So the platelet count. So when that's low, the prothrombin's not there, fibrinogen and factor VIII, then we run into a problem that if this patient should fall or even just slightly bump their arm on the side railing or something, you're looking at it and you're like, where did that huge bruise come from? That might be an indication of something going on. So, we need to look at those things. Formation of bilirubin from the breakdown of red blood cells, phagocytosis by the Kupffer cells, storage of fat-soluble vitamins and minerals such as iron and copper that are needed for red blood cells, detoxification of medications and all kinds of things that can do harm in the body. And you'll hear Ms. Serpaz talk about in metabolism that when, that is being impaired, that by the liver not functioning properly, and they can get cirrhosis and that kind of thing, that ammonia can rise in the blood and cause problems with sensorium in the patient. They may get confused, they may get combative, that kind of thing. And then also the production of bile, which is stored in the gallbladder but produced by the liver. And that is also helped to, it helps to get rid of cholesterol, but also helps with emulsification of fats and that kind of thing. All right, so that's the liver. So lab tests that are specific to the liver, and you need to see the clinical lab sheets for the values. Again, albumin, like I mentioned, total protein, total bilirubin, alkaline phosphatase, which is ALP, aspartase aminotransferase, which is AST, alanine aminotransferase, which is ALT, prothrombin time, or PT, which has to do with coagulation. Does that, is the blood going to coagulate like it's supposed to? Or, is the bleeding time as such that the patient's going to bleed? And of course, the international normalized ratio, or the INR, where, some patients are kept at a higher level because they have a propensity for clots. Maybe they've had a stroke before or whatever, and Ms. Hanhart will get into that. So that has to do with coagulation as well. So they're given, Coumadin, or some, and so their INR is very important. Their PTT as far as heparin. So those are very important, and the platelet count. Okay. So you can look at your lab sheets and be able to tell what those normal values are. And yes, you have to know the labs. Again, Ms. Serpaz is going to go over these same labs when you get into metabolism as well as ammonia. Okay. All right. There we go. So the next organ I'm going to talk about is the gallbladder with cholecystitis. Okay, before the liver, we're going to talk hepatitis is the inflammation of the liver, and we're going to talk about the viruses that can cause inflammation of the liver. The gallbladder is cholecystitis, and we're talking about the inflammation of the gallbladder. So this can happen from infection. It can happen with gallstones, which is called cholelithiasis, and we'll go into more of that when we do the exemplars. And like I said, the gallbladder is located on the undersurface of the right lobe of the liver. So you can see the previous picture of the liver, and then the picture of the stomach has it kind of flipped up so you can see the sac, okay? And of course, the function of the gallbladder is to store bile and to take in water to help concentrate the bile so that it can flow from the cystic duct. Okay, the hepatic duct comes and brings the bile to the gallbladder and meets with the cystic duct to form the common bile duct. And that's where the pancreatic duct meets with them and then flows to the duodenum to be able to digest food. Okay, so those ducts are very important too. And I'm not talking about DUCKS, I'm talking about DUCTS. Okay, because if there are gallstones, then they can back up anyway and cause problems. You know, the liver can get inflamed, so you'll see an increase in all those values of the labs I showed you, as well as the pancreas. You know, you have a gallstone that blocks that pancreatic duct, and it can cause pancreatitis. So speaking of the pancreas, and we'll be doing the exemplar of pancreatitis. So it's located in the upper left abdominal quadrant behind the stomach, between the curvature or the curve of the duodenum and in front of the spleen below the diaphragm. Okay, so if the pancreas, okay, we're talking about inflammation, right, of these organs. So if the liver becomes inflamed, it will become edematous. We can't see it. If we perform percussion, you know, we might be able to hear the difference. We're not well vested into palpating different organs as well. But from an ultrasound, they can tell, you know, the difference in the size of the liver. And then the pancreas as well, or on a CT scan, can also see that it is edematous. We won't see the redness, we won't see the warmth, but the warmth might be illustrated into an increase in temperature. Okay, so you can see where the pancreas is. It shows you the common bile duct, where the duodenum is located, which is the very first part of the small intestines that links to the pylorus of the stomach and then to the rest of the small intestines. And as you can see, the colon and stuff goes on either side. So the functions of the pancreas, the endocrine functions, are secretion of hormones, the glucagon and insulin that happens to influence the glucagon, help to influence the glycogen with the liver, the insulin, the production of insulin manages the glucose and how it's delivered to the cells. Secretion of amylase digests starch. The secretion of lipase converts emulsified fats into fatty acids. Okay, and so those two are really specific to the pancreas. Now, how are we going to see if the pancreas is, secreting enough insulin for the glucose? Is to measure the glucose itself. So when they're hyperglycemic, meaning They have more glucose than the reference range, and I think it goes up to 110 for fasting. You know, there is a functional impairment with the insulin, and then also when it's inflamed, the amylase and lipase. And it also produces bicarbonate juice, which neutralizes the gastric acid into the duodenum to prevent damage to the duodenal mucosa. And that's very important too. Okay, these lab tests are specific to the pancreas. They're not on the clinical lab sheet, but after meeting today, we'll see if we can't put them on there, as well as the sedimentation rate for you. Serum amylase, the normal range is 30 to 170 units per liter. Okay, but now, used to be the amylase takes a certain amount of time to be able to increase, and then the lipase a little bit longer. But now the gold standard is looking at the serum lipase, and that normal range is 14 to 280 units per liter. So anything above that indicates pancreatitis. Okay. And then, of course, a lab that's not specific to the pancreas, but comes when there's a basic metabolic profile or a complete metabolic profile or fluid and electrolytes, would be the glucose level. And that is also on your, clinical lab sheet. So here's the stomach. The exemplar is going to be peptic ulcer disease. It's located in the upper left quadrant of the abdominal cavity to the left of the liver. So it's kind of has a curvature to it. It runs from the left, can go mid, and then you see where the pylorus is, and that's going to hook onto the duodenum that comes up. And then you can see they have the liver kind of lifted and the gallbladder skewed up, so that you can see that it's on the underside of the liver. So the functions of the stomach, that can be impaired with inflammation. It is a reservoir for food, so digestion can occur, and that digestion is mechanical as well as chemical. Most digestion occurs in the pylorus and the duodenum of this, the pylorus going into the duodenum of the small intestines. So, even though digestion occurs in the stomach, mechanical and chemical, when we talk about ulcers, it can cause bleeding. It can cause that food not to be digested in such a way that it can be completely digested in the small intestines and mainly in the duodenum and stuff. So, we need to be mindful of that. And as we go through the exemplars, we'll see the impairment that can occur. Also, the stomach produces highly acidic gastric juices for digestion, hydrochloric acid. When we're stressed, steroids, certain disease processes and things, and certain medications can cause a patient to have, the propensity or set up the environment in there so that they will get an ulcer. So we're going to look at the meds, everything with that exemplar, and look at how it would be treated outpatient as opposed to inpatient complications, etc. So the small intestines, this is where Crohn's can occur. Now, Crohn's disease can occur anywhere from the esophagus all the way to the anus, okay? But it also really can occur in the small intestines. Now, the small intestines, they're 1 inch in diameter, but they're 20 feet long. And as you can see, they're all curled up in the middle, going to the mid-lower abdominal cavity. Okay. And that the large intestines or the colon kind of surrounds the small intestines. So the functions of the small intestines that can be impaired with inflammation. The small intestines are made up of 3 sections: the duodenum, the jejunum, and the ileum. So the duodenum is the first 10 inches, the jejunum is approximately 8 feet, and the ileum is approximately 11 feet. And digestion is completed in the small intestines, and the nutrients are absorbed into the blood and lymph systems in the small intestines. So all that digestion can be functionally impaired. So if those nutrients can't be absorbed, those patients are going to be malnourished or have malnutrition, which then makes them immunosuppressed. Okay, and we will talk about all of that in class as well. The large intestines, Crohn's can happen there as well as ulcerative colitis, which the ulcerative colitis is usually in the descending colon, sigmoid, rectum, anal canal, and anus. Okay. And then Crohn's, like I said, small intestine, large intestines, all the way up. So the location of the large intestines, or the colon, is encircling the small intestine's right lower quadrant across the mid-abdomen to the left lower quadrant, okay, and then down, descending sigmoid, colon, rectum, anal canal, and anus. It's 2.5 inches in diameter, so, over twice as big as the small intestines, but only 5 feet long, okay? The functions of the large intestines that can be impaired with inflammation: absorption of water, okay? It can increase it, so patients get dehydrated, they can't absorb the water, so there's an increase in the large intestines. Minerals and vitamins that are not absorbed readily with the large intestines. And then the elimination of undigestible materials such as fiber, cellulose from vegetables and fruits and that kind of thing. Also, normal flora of the colon produces vitamin K, okay? And so what does vitamin K have to do with the body? I'll let you write that down, and we'll go through that when we get to Crohn's and ulcerative colitis. They also produce, that normal flora, other vitamins and inhibit the growth of pathogens. So if that whole place is inflamed, it leaves the colon open for pathogens to invade. Ulcerative colitis is just what it says. It creates ulcers. Crohn's is a different animal. We'll go, we'll go into that when we do the exemplars. And then the defecation reflex, to be able to defecate and get rid of the feces that's in the colon. That reflex with ulcerative colitis and Crohn's, they have multiple bowel movements and watery diarrhea, stools. And with ulcerative colitis, it's the tenesmus, that the sudden urge to defecate, and it causes extreme pain and things. So all of that is very important, and can be impaired with inflammation. So when we talk about ulcerative colitis and Crohn's, we will also talk about the surgery that can go along with that. And I think in elimination, Ms. Harris will also cover, with diverticulitis, the possibility of a surgeon going in and creating an ostomy for the ultimate bowel rest. They may resection it, take out the diseased part, and give them a colostomy, which would be in the large intestines. depending on where they put theostomy, depends on what it's named. Ileostomy for being in the ileum, a jejunostomy in the jejunum, and where that ostomy is placed will determine what consistency of stool will result. Okay, so this is what a healthy stoma looks like. They take the intestines and they create incision and kind of pull it out and flower and open it and make a little flower bud. And it should stay nice and pink or pinkish red for it to be healthy and to make sure the circulation is there. If it's gray, if it's blue, if it's pale, then circulation to that organ is impaired and we need to do something about it. And the surgeon and or GI doctor needs to know about it immediately. And we will talk more about that again as we do the exemplars in that first class. So this is the end of my presentation. I hope this was a nice review and a preview of what's to come. Jot down any questions and I will be more than happy to answer them in that first class before we get started on the exemplars. I will need you to read about the exemplars before class, and because I will be putting you in groups to be able to come up with what cues are you going to recognize. Now, in inflammation and in the concepts, when we're teaching you this, it's already presented with the exemplar, the disease process evident. But in the emergency room or as things come up on the floor, there could be complications of other surgeries or the disease process. You're going to have to come up with being able to recognize those cues, analyze them, and figure out what does this mean and create a hypothesis. So what's the problem? What's going on? And then we're going to have, to prepare solutions. So what are we going to do about it? And then act on those solutions, taking action. What do we prioritize? What's got to be done first? Second, third, fourth, all the way down. And then evaluating what those actions, did they work? Do we have to do something different? Or, what's going on? Is there a complication that's occurring? So we need to know complications, and then we need to trend the data, of the assessments. When I looked at it earlier in my 12-hour shift, that first 4 hours, it looked fine. And now I'm seeing it, seeing something change that's different. So now I'm assessing it again and it's different. So what am I seeing? Is there a complication occurring? What's going on? So all of those things are going to be addressed. And those are the kinds of things that are going to be coming about on your test questions. So, and you'll hear more about that in inflammation 2. We will be working through a case study and then possibly some test questions if we have time. All right, so that's it for this preview, and I appreciate your attention. Like I said, please bring your questions and things to class, and I will answer them. And I will also post the discussion board as open after that first class when everybody has had time to go through the first class. So by Wednesday of next week, the discussion board will be open, but you guys are going to be much too busy. And we'll talk about how to study for these things and, what will help you be successful, because that's why we're here, is to help you succeed. So have a good day, and I will see you in the halls. Take care.